So my name is Taylor Logan, and for my project, I did a Seizure Safe Schools professional development training. So for the introduction, 1 in 26 people will develop epilepsy. In 2023, it was discovered that 470,000 children live with epilepsy in the United States, and out of that number, 4,500 of them live in Connecticut. Jessica Lafredo, who is a teacher in Connecticut and also has a son with epilepsy, said, "Not only is this bill important because I have a child with epilepsy, but also because every student, regardless of their diagnosis, should feel safer at school. It might even invite students back to school instead of choosing the homeschool setting. Training school personnel empowers them to take quick action and ensures everyone who cares for students has the skill set needed to administer seizure first aid in or out of the classroom. This legislation also provides peace of mind and support to parents who are sending their child off to school." Training was done at a Midwestern school district, which caused schools' nurses' confidence to increase. They were also the first district to do a district-wide change after the Seizure Safe Schools Law was put into effect in their state. In 2009, it was discovered the economic burden that epilepsy takes on someone who lives in the United States is over $9.5 billion due to healthcare costs, loss of employment, loss of wages, and loss of productivity. So the main objective of this project is to show how staff being trained on all aspects with epilepsy helps students with epilepsy in schools. And this is due to the fact that students with epilepsy currently have a higher risk of anxiety, depression, and negative self-image due to the fear of having seizures and the stigma from their peers. The current epilepsy training programs focus solely on seizure recognition and seizure first aid. Some expand into rescue medication administration. If students start feeling safer in school, this will lead to parents feeling safer when their child is at school, and neurologists feeling better when their patients are at school. Sarah Franklin from Alabama said, "We are committed to advocating for the rights of everyone impacted by the epilepsies in our state. The Epilepsy Foundation's goal is to build an empathetic next generation who welcome people living with epilepsy as their friends, neighbors, and colleagues, and who are prepared to help them with proper seizure first aid." So my project has 3 different parts: the PowerPoint, which goes over the Seizure Safe School Law, fast facts about epilepsy, how epilepsy affects students, how epilepsy and sports intermingle, different seizure triggers, different seizure types, drug-resistant epilepsy, diet therapies, seizure first aid, rescue medications, seizure alert dogs, seizure detection devices, seizure action plans, different studies done on different things having to do with epilepsy, organizations that support seizure safe schools, examples of the Seizure Safe School Law from other states, and organizations that have resources for them, their students, and parents if they ever need them. The handbook, which is for faculty and staff, which highlights the Seizure Safe School Law, the different types of seizures, different types of seizure detection devices, different types of seizure rescue medications, and steps for seizure first aid. And of course, the poster, which includes steps for seizure first aid, and it'll be posted around the schools and in the classrooms. And you can see pictures of the handbook and the seizure first aid poster right there. So the significance of this project is the only other training for schools that is this advanced is done by the Epilepsy Foundation, and they do not even go into this much detail. Districts in Connecticut are not required to use the Epilepsy Foundation training. Districts in Connecticut are not required to use all the same training as each other. This would give faculty and staff at the districts almost as much information and training as the neurologists have. They just wouldn't know how to read the test results to diagnose for epilepsy. This would help make faculty, staff, students, parents, and doctors all feel better about working together because everyone would be on the same page when it came to how to help the student if a seizure were to occur. And the CDC reports that when students, families, the schools, and communities work together to address the needs of chronic health conditions, academic success increases. So my method was that I did research on the Seizure Safe School Law and contacted my camp director, Mike Riddell, for some statistics that their organization, known as EPI, had. I submitted my idea for approval. I continued doing research on the Seizure Safe School Law, and writing my proposal. I turned in my proposal. Continued doing research on the Seizure Safe School Law. Again, continued doing research and started creating the PowerPoint. Continued working on the PowerPoint, and I emailed Sarah Corba about receiving statistics that EPI had. For those that don't know, Sarah Corba works on the board for EPI. Then I created the poster, started working on the handbook, and emailed my professor a question. I got a response about my question and registered for the Epilepsy Coalition Conference. I finished the handbook, started working on the final report, and scheduled time to meet with my professor. I met with my professor and started working on my presentation. Continued working on my presentation and attended the Epilepsy Coalition Conference. And then I got sick, so I could not do some work for a little while. But then I was able to finish my presentation and send everything to my professor to get looked at. And now I am here recording my project. So this is where the PowerPoint and the training comes in. So just some facts about the Seizure Safe School Law in Connecticut. On June 28th, 2023, Governor Ned Lamont signed House Bill 6882, making Connecticut a seizure-safe school state. There are now 22 states in the United States with a Seizure Safe Schools bill. It protects the physician-directed care in the school and helps school personnel when it comes to their students with epilepsy and other seizure disorders. There are 470,000 children living with epilepsy in the United States as of 2023, and 4,500 of them were in Connecticut. It requires local and regional boards of education to require in-service training to teachers, administrators, and pupil personnel on seizure recognition, seizure first aid, and seizure action plans. Also, school personnel who administer medication receive training on how to administer seizure rescue therapies, which include the vagus nerve stimulator magnets. So this is some people's views on the Seizure Safe School Law. Again, Jessica Lafredo, who is a teacher with a son who has epilepsy, said not only is this bill important because I have a child with epilepsy, but also because every student, regardless of their diagnosis, should feel safer at school. It might even invite students back to school instead of choosing the homeschool setting. Training school personnel empowers them to make quick action and ensures everyone who cares for students has the skill set needed to administer seizure first aid in or out of the classroom. This legislation also provides peace of mind and support to parents who are sending their child off to school. Sarah Franklin from Alabama again said, "We are committed to advocating for the rights of everyone impacted by the epilepsies in our state. The Epilepsy Foundation's goal is to build an empathetic next generation who welcome people living with epilepsy as their friends, neighbors, and colleagues, and who are prepared to help them with proper seizure first aid." So here's some quick facts about epilepsy. The World Health Organization documents that epilepsy is the most common and serious brain disorder worldwide with no age, racial, social class, national, or geographic boundaries. The Center for Disease Control and Prevention estimates that 3.4 million people in the United States have epilepsy. Epilepsy is the underlying tendency of the brain to produce seizures, and seizures are sudden abnormal bursts of electrical energy that disrupt the brain functions. Seizures from epilepsy affect a variety of mental and physical functions. 2 or more unprovoked seizures qualify someone to be diagnosed with epilepsy. Nearly 150,000 new cases of epilepsy are diagnosed in the United States each year. In 2013, the CDC estimated that 467,711 children were diagnosed with epilepsy. 1 in every 26 people will be diagnosed with epilepsy in their lifetime. And in 2009, the U.S. economic burden when it comes to with epilepsy was estimated to be over $9.5 billion due to healthcare costs, loss of employment, loss of wages, and loss of productivity. So epilepsy does have a past. It was known as a sacred disease. People believed it was caused by possession by evil spirits or gods. Epilepsy comes from the Greek word epilamvenom, which means to be seized. Treatment used to be associated with religious, supernatural, occult practices, and magical powers. Mesopotamian, Hebrew, and Egyptian civilizations knew of the condition for centuries. The Greeks of the Hippocrates school mentioned epilepsy as a sacred disease and used the practices of the time period, even though they thought the cause of epilepsy was in the brain. Men with epilepsy would have their testes cut off, and women with epilepsy would be killed to try to prevent the spreading of the condition. And John Hewlings Jackson created the field of neurology in 1862 by treating his wife's form of epilepsy. So epilepsy and students. Epilepsy affects 6 in 1,000 students in the United States. Having seizures at school can be anxiety-provoking and embarrassing for students. The CDC reports that when students, families, the schools, and communities work together to address the needs of chronic health conditions, academic success increases. Children with epilepsy deal with physical complications from their seizures, along with the stigma from their peers. Due to the fear of having seizures, children with epilepsy have a higher risk of negative self-image, anxiety, and depression. They are also at a greater risk for learning and academic achievement problems than peers who have other chronic disorders, and it is linked to poor academic performance. So epilepsy in sports. Previous studies have shown sports have positive effects for people with epilepsy, such as decrease in seizure frequency, cardiovascular status improvement, and increase in life quality, self-esteem, and well-being. People with epilepsy are often advised not to participate in sports or physical activities due to fear, overprotection, and lack of knowledge. Schools and educational institutions need to improve information provided and provide training for health professionals, teachers, family members, caregivers, students, and school employees when it comes to epilepsy and exercise. So here are just some seizure triggers. They're the most common ones that you see, but usually it's specific time of day, lack of sleep, illness, flashing lights or patterns, alcohol or drugs, stress, menstrual cycle or other hormonal changes, not eating well, specific foods, use of specific medications, and missed medications. So then here are the seizure types: absence seizures, focal aware seizures, focal impaired awareness seizures, tonic seizures, atonic seizures, clonic seizures, focal bilateral tonic-clonic seizures, tonic-clonic seizures, myoclonic seizures, epileptic or infantile spasms, febrile seizures, scholastic and diacrastic seizures. So absence seizures, they're a short period of staring into space. Their generalized onset seizure begins in both sides of the brain at the same time, usually only affect the person's awareness during the seizure, and they have immediate recovery. Most common with ages 4 years old to 14 years old. Teens and adults do get them too. Common mistake for people to mistake them for daydreaming or not paying attention. Most common sign of absence seizures is if they start having trouble in school. Most of the time, no first aid is needed for this type of seizure. When many happen in a day, they may lose track of time or what is going on. For kids, they may miss instructions from the teacher, not be aware of what is happening in the class, or have incomplete work. Absence seizures can cause kids to have trouble learning in school, have social problems, and misbehave more often. So here's a video with an example of what absence seizures looks like.
What happens if the alarm goes off? Jen? Hello? Did you forget your line?
Oh, hold on a sec. I think she's having a seizure.
What?
The object of this mission is to go as far into the earth as possible.
So there's two categories for absence seizures. There's typical and atypical. For typical, they're most common, suddenly stops without warning, eyes may turn upward and start to flutter. They're less than 10 to 20 seconds and momentarily confused, and then they're back to normal. Atypical, they're longer with a slower onset and offset and have different symptoms. They still stare into space. They may have a change in muscle tone and movement, such as blinking over and over, smacking the lips or chewing, rubbing their fingers together, and they can last up to 20 seconds or more. So here are some focal aware seizures. Begins in one side of the brain. The most common type of seizures experienced by people with epilepsy. There's no confusion, no loss of awareness, more likely in people who have had head injuries, brain infections, strokes, or brain tumors. They're able to recall events during the seizure. When it ends, the person usually goes back to what they were doing before. Can be a warning or aura for a stronger seizure. They vary a lot in how often they occur. You may not be able to tell if someone is having one since the person is very alert and able to interact. They are diagnosed through medical history, EEGs, MRIs, and CAT scans. They can be treated with anti-seizure medications, devices, surgery, or diet therapies. So here is what one may look like.
Let's see what a focal seizure can look like and how you can help. Hi, Annie. You okay?
Hi, I'm good, thank you. How are you?
Very well, thanks. I think that's everything sorted for this morning's order.
Oh, that's good, because the Davis order is ready as well.
Oh, good. Is there anything else you need?
Yeah, there is something.
Oh, yes. Annie? Annie, are you okay? Annie? Annie, I think you're having a seizure. If someone is having a focal seizure, here's how to help. Everything's going to be okay. Focal seizures can be frightening and disorientating for the person, so be calmly reassuring. Take your time, Annie, it's fine. You're at work in the warehouse. Only intervene if you need to guide them away from danger. Don't make any abrupt movements that could frighten them. Don't try to bring them round or restrain them. Are you okay, Annie? Everything's going to be fine. You've had a seizure. To the seat.
So there's focal impaired awareness seizures. They begin in one side of the brain. They're the most common type of seizures for adults with epilepsy. When the seizure begins in one side of the brain and the person has confusion or a change in their level of awareness during some or all of it, they usually start in the temporal lobe or frontal lobe of the brain. If they start in the frontal lobe, they are usually shorter seizures than if they start in the temporal lobe. They include involuntary movements called automatisms, which include rubbing of the hands, lip smacking, chewing, bicycling of the legs, pelvic thrusting. Sometimes it may start out as a focal aware seizure. Some focal impaired awareness seizures can spread to both parts of the brain. So here's an example.
Okay, you're okay, Adam? Who's having a seizure? He'll be fine. It'll pass. Do you need help? Do you want me to call 911? No, it's not an emergency. You're okay, Adam. I'm just guiding you, okay?
Happen again?
You just had a seizure.
Here's more information about focal impaired awareness seizures. The seizure can wipe out memories of events before and after it. People can repeat words and phrases, laugh, scream, or cry. Some people may walk into traffic or try to take their clothes off. Anyone can have these seizures, and the cause is unknown as to why. People more likely to have these types of seizures are people with head injuries, brain infections, strokes, and brain tumors. Seizure first aid should be used in this situation. If a person has a rescue medication, it should be used as well. They are diagnosed through observation, EEGs, MRIs, and CAT scans. They are treated through medication, surgery, vagus nerve stimulation, responsive stimulation, and dietary therapies. Next up is tonic seizures. The body, arms, and legs become stiff or tense. A person may be aware or have a small change in awareness. They usually happen during sleep, less than 20 seconds, can fall if standing. It happens in one area of the brain. Stiffening of the body may begin in one area and stay local, which then they're called focal tonic seizures. It happens in both sides of the brain. Both sides or the whole body may become stiff, then they're considered generalized tonic seizures. It can happen in anyone. When it ends, the person may or may not be sleepy or confused. No first aid is needed. Some people have one and others have clusters. And MRI and EEG help diagnose tonic seizures. Anti-seizure medicines, diet therapies, devices, and surgery are treatment options. Now we have atonic seizures. Muscles become limp. Part or all of the body can become limp. The eyelids can droop. The head can nod or drop forward, and the person can drop things. The person can drop to the ground. The seizures usually last 15 seconds. They can get injured, so they may be wearing a helmet or some other protective gear. They are also called drop attacks or drop seizures. They start in one part of the brain, then they're considered focal motor atonic seizures. If they start in both parts of the brain, they are considered generalized onset atonic seizures. They are usually start in childhood and last into adulthood. They can be seen in Lennox-Gastaut or Dravet syndrome. They can or cannot be confused, and they can return to their usual activity quickly or may need to rest. So here's an example.
Yeah. What's that bird over there?
Gorgeous, isn't it?
I think it's a kite.
Oh, you all right, babe?
Yeah. Yeah, sorry about that.
Let's get you up.
Epilepsy Society, supporting everyone affected by epilepsy. To find out more, go to www.
So clonic seizures, it's repeated jerking that cannot be stopped by restraining or repositioning the body. It's rare and it commonly occurs in babies. They last few seconds to a minute. If they follow with stiffening of the muscles, they can last 1 to 2 minutes. It can be hard to distinguish from a myoclonic seizure if it's in one area of the brain. When it starts in the motor area, focal clonic seizures, and they only affect one side or part of the body or face. If it's in both sides of the brain, they're considered generalized clonic seizures and affect both sides of the body or whole body at once. And it can affect people of all ages. More about clonic seizures. In babies, they happen for a short period of time and not very often. If it is a focal onset, the person can be aware during it. If it is a generalized onset, the person usually is not aware during it. The person can fall if they are standing during it. They affect the motor and sensory parts of the brain. The frequency depends on the cause and the person. Someone can tell someone is having a clonic seizure if the person seizing is showing rhythmic jerking movements of the arms and legs. Written reports of what is happening in EEG and a video EEG are used to diagnose clonic seizures. Certain seizure medicines help prevent clonic seizures. So next up is focal bilateral tonic-clonic seizures. They start in limited areas of the brain and spread to involve both sides. More than 3 out of 10 people with focal epilepsy have these types of seizures. Sometimes the person does not recall the beginning of the seizure. The bilateral tonic-clonic part lasts 2 to 3 minutes. They can happen to people of any age. They start suddenly. The movements can be strong and forceful. The seizure can begin with an aura or focal onset aware seizure. Smell, nausea, change in sensation or movement. The seizure can begin with a focal onset impaired awareness seizure, which would make them not aware of what is happening. Some more information about these type of seizures is the bilateral tonic-clonic part begins with the tightening of the muscles. So it could be air going past the vocal cords to cause a cry or groan, falling to the floor, tongue or cheek being bitten, or breathing being impaired. Jerking movements happen in the necks. Arms, legs, and face jerk repeatedly and quickly with bending at the knees, elbows, and hips. The jerking eventually slows down and stops. Someone can lose control of their bladder and bowels. Consciousness slowly returns. The person can be drowsy, confused, agitated, or depressed for hours or days. The active part lasts 1 to 3 minutes. It can take hours or days to fully recover. A tonic-clonic seizure that lasts longer than 5 minutes is a medical emergency. If they do not return to normal or another seizure occurs before they do, this is a sign of status epilepticus. These seizures are diagnosed with EEGs and MRIs, and they can be treated through medication, surgery, neurostimulation devices, and diet therapy. So tonic-clonic seizures. Most people think of this type of seizure. It used to be called grand mal. The tonic phase is when all the muscles stiffen, there's air being forced past the vocal cords, causing crying or groaning. Person loses consciousness and falls, and the person may bite their tongue or cheek. Then the clonic phase is when the arms and usually the legs begin to jerk rapidly and rhythmically, bending and relaxing at the elbows, hips, and knees, and the jerking slows and stops. A person's face may turn blue if they have trouble breathing or the seizure lasts too long. The person may lose control of bladder or bowels. Consciousness returns slowly and lasts 1 to 3 minutes. More about tonic-clonic seizures. Afterwards, the person may be sleepy, irritable, or depressed. Longer than 5 minutes, needs immediate medical attention. If they have rescue medication, give it to them. Call 911 if they do not have rescue medication or it does not work. If they start on both sides, it's a generalized onset motor seizure or generalized tonic-clonic seizure. If it starts on one side and spreads to affect both sides, focal to bilateral tonic-clonic seizure. These types of seizures can affect children and adults. The person can be sleepy or confused for minutes, an hour, or longer. And anti-seizure medicines, rescue medicines, diets, and devices are used to treat these types of seizures. Here's a video that shows these seizures. So myoclonic seizures, they're brief shock-like jerks of muscle or groups of muscles. They don't last more than a second or two. There can be just one, but sometimes many will occur within a short amount of time. Myoclonus can occur in people without epilepsy, myoclonic seizures when it results in abnormal brain activity. Someone can drop an object or fall during a seizure. After the seizure, the person returns to what they were doing before or during the seizure. No first aid is needed. These seizures are overlooked because they look like regular movements. They are mistaken for tics, tremors, or clumsiness. They are diagnosed through medical history and EEG. Anti-seizure medicines treat these seizures. So here's an example.
How were you working till last night? You look exhausted.
Oh, it was so late. I'm so tired, but just gonna get that coursework done for next week.
This will get you going again.
Thanks, Dad.
You okay?
Yeah, I'm fine. I just don't have any clean glasses. I meant to do it yesterday.
While you were working.
Thank you.
Epilepsy Society, supporting everyone.
So some more about myoclonic seizures. There's juvenile myoclonic epilepsy, where it involves the neck, shoulders, and upper arms. Most often occur after waking up, begin around puberty or early childhood, and people who have a normal range of intelligence. Most people have to take medication for the rest of their lives, and it can be triggered by being overtired or flashing lights. Lennox-Gastaut syndrome, uncommon syndrome that involves multiple seizure types, begins in early childhood. Myoclonic seizures include neck, shoulders, upper arms, and face, can be strong and difficult to control. And progressive myoclonic epilepsies, combination of myoclonic seizures and tonic-clonic seizures, treatment is not successful for very long. Patients develop intellectual disabilities, coordination, and walking problems over time. So then there's epileptic or infantile spasms. They last 1 to 3 seconds, and it's of the arm, leg, and head flexion or extension. Spasms can occur in clusters of every 5 to 10 seconds over a 5 to 10 minute period. Spasms are seen after waking up. Clusters are seen throughout the day. Infants can cry during the cluster and sometimes get misdiagnosed with colic. An epileptic spasm can occur due to an abnormality in the brain or reflects a more generalized brain problem. Spasms that are due to small abnormalities can affect one side of the body more than the other or may pull the head or eyes to one side. Spasms commonly occur in infancy. They also occur in West syndrome, infantile spasm syndrome, or Abtahara syndrome and Lennox-Gastaut syndrome. Spasms will usually go away by the preschool years and be replaced by other seizure types. They have a higher rate of drug-resistant epilepsy. There are significant developmental concerns over time. Video recordings help determine if someone is having an epileptic spasm, and clusters of epileptic spasms do usually require rescue medications. So here's a video about epileptic and infantile spasms. So febrile seizures happen to kids ages 3 months to 6 years due to a high fever. It's 2% to 5% of children. Slight tendency for them to run in families. It comes out of the blue before someone realizes the child is ill. The seizure alerts the family that the child is ill. Perform seizure first aid to treat the febrile seizure. Most children will not require daily seizure medication after the febrile seizure. Some children may require a rescue medication if they have a history of prolonged febrile seizures. And here's a video about febrile seizure.
Today's topic is febrile seizure. A febrile seizure is a convulsion or seizure in a child associated with a high body temperature above 100 degrees Fahrenheit. It usually happens during the first few hours of a fever. Febrile seizures occur in children between 6 months and 5 years of age, but more prevalently for children around 12 to 18 months of age. Young children affected usually have normal development without a history of neurologic symptoms. Children younger than 12 months at the time of their first febrile seizure have a 50% chance of a recurring episode, while children over 12 months when they have had their first febrile seizure have about 30% chance of a recurring episode. Febrile seizures are not considered epilepsy. However, there is a slightly increased risk for children who experience febrile seizure to develop epilepsy. Febrile seizures can be very frightening and can look very serious, but they are usually harmless and do not indicate a serious health condition. There are two types of febrile seizure: simple and complex febrile seizures. Simple febrile seizures are the most common type, lasting from a few seconds to 15 minutes. They are not restricted to one part of the body, such as the arm or leg, and do not recur within a 24-hour period. Complex febrile seizures are less common and can last longer than 15 minutes. The child may experience more than one episode within 24 hours, and this type is confined to one part of the body. Causes. Studies suggest that febrile seizures may be linked to the way that a child's developing brain reacts to high fever. The fevers that trigger the condition are most often caused by a viral infection, and less often by a bacterial infection. Influenza and the virus that causes roseola are often common culprits. Vaccinations. Fever may accompany some childhood immunizations, including diphtheria, tetanus, and measles, mumps, rubella, or MMR vaccinations. It should be noted that the fever accompanied by this vaccination causes the seizure, and not the vaccination itself. Most kids who get febrile seizure have a family history of the condition. Symptoms: stiffened body, shaking, jerking, or twitching of arms and legs, loss of consciousness, irregular breathing, vomit or urinating during the convulsion, moaning or crying. Diagnosis and treatment. To make a diagnosis, the doctor will review the child's medical history and developmental history to eliminate more serious causes of fever and seizures, such as meningitis and encephalitis. Blood and urine tests may be used to detect an infection and know what kind it is. If an infection is suspected in the brain, a spinal tap may be needed. If the child has a complex febrile seizure, an electroencephalogram, or EEG, may also be recommended to measure brain activity. The doctor may also recommend an MRI to check the child's brain. This is done if the child has an unusually large head, a febrile seizure that lasted for a much longer period, an abnormal neurological evaluation, symptoms and signs of increased pressure in the brain. Treatment. In most cases, febrile seizures will resolve on their own within a few minutes. If your child is experiencing a febrile seizure, follow these steps. Place the child on his or her side on the ground or floor, or any surface where he or she won't fall to avoid choking. Start timing the seizure to keep track of how long it lasts. Loosen any clothing around the neck or head. Watch for signs of breathing problems. Stay close to watch and comfort the child. Do not try to restrain or hold the child. Do not put anything in the child's mouth. Do not try to put the child in lukewarm or cool water to cool off. If the seizure lasts more than 5 minutes or the child turns blue, call 911. For seizure that lasts longer than 5 minutes, the doctor may recommend medications. The child may be hospitalized for observation if the seizure is prolonged. Thank you for watching our video. Please do not forget to like.
So a simple febrile seizure is generalized full body convulsions, less than 15 minutes and no more than 24 hours. Whereas a complex febrile seizure or complicated febrile seizure, they start focally with one part of the body moving more than 15 minutes and occur more than once within 24 hours. For febrile seizure tests, the doctor will ask questions suggesting an illness. They'll do blood tests, a spinal tap, EEG, and MRI. So, lastly, there are gelastic and diacrastic seizures. Gelastic and diacrastic seizures are focal seizures that start in the hypothalamus. Gelastic seizures have bouts of uncontrolled laughing or giggling. Diacrastic seizures is when the person makes a crying sound. The person cannot control their emotions. The person is aware of what is happening during these seizures. They usually have a lesion on the hypothalamus called a hematoma. Their aura may show them looking startled or panicked, having butterflies in their stomach, tickling in the chest, headache, lip smacking, or swallowing. They may stare and their eyes may dilate. Children may look for comfort from a parent or favorite toy or run to a safe space. These seizures have been reported to occur as much as 100 times a day. They're diagnosed when diagnosed with another type of seizure. This is about a little boy who has one of these types of seizures.
Let's try to get a 1.
Robert Cho says his son Justin has always been a happy child. So he never gave it much thought when Justin would laugh, even though at times for no apparent reason.
Ever since he was an infant, he would giggle every now and then, and it would be very short-lived, anywhere from about 2 to 5 seconds.
But after Justin suffered a classic epileptic seizure at home, hospital tests revealed that this laugh was the symptom of a serious problem.
These are episodes out of the blue where a child may laugh but it's really a seizure.
Known as gelastic epilepsy, the seizures are caused by a benign mass or lesion deep inside the brain. In the past, curing it meant open brain surgery that carries high risks and requires a long recovery. But at UCLA, surgeons take another approach. Here, they make a tiny incision in the skull, and using sophisticated GPS-like mapping, they insert a tiny laser fiber directly into the problem area.
And we essentially cook it with thermal energy. So we're cooking this lesion from the inside out, and that cures the epilepsy.
And the fact that it's a minimally invasive procedure meant Justin could get back to his normal activities like playing soccer almost immediately. Now, whenever his family hears him laugh, they know he's happy because the epilepsy is gone.
Nothing. Zero. No gelastic seizure. No full-on seizure. It's a miracle.
At UCLA Mattel Children's Hospital, this is Clark Powell reporting.
So then there's drug-resistant epilepsy, where a person has failed to become and stay seizure-free with trials of 2 or more anti-seizure medications. Anti-seizure medications should be chosen based on the person's seizure type. They should be tolerated by the person and tried alone or together with other anti-seizure medications. Seizures can be uncontrolled because the diagnosis is wrong, the treatment is wrong, triggers or lifestyle factors affect seizure control, or properly diagnosed seizures do not respond to the best treatment. Epilepsy and diet therapies. So the modified Atkins diet is a diet therapy for drug-resistant epilepsy. A study in India was done on people ages 10 to 55 years old with drug-resistant epilepsy. They took their anti-seizure medication while doing the modified Atkins diet. Less than 50% showed reduction in seizure frequency. Then there was the ketogenic diet therapies, which have been used for the past century to treat epilepsy. In 1921, R.M. Wilder presented a case with patients ages 13 years old, 23 years old, and 31 years old who responded to the ketogenic diet for treatment for their epilepsy. The ketogenic diet is a high-fat diet that makes the body produce ketones through fat metabolism, resulting in ketosis. Both diets replace fasting, which used to be used to treat epilepsy. A modified Atkins diet limits carbohydrate consumption while increasing fat with adequate protein. It is not as restrictive as the original ketogenic diet from the 1920s. So, epilepsy in Ramadan. An observational study on Muslim patients with active epilepsy that are fasting on average 16 hours a day. Seizure frequency for each seizure type was followed for over 3 months: Shaban, Ramadan, and Shawwal. 321 Muslim patients, median age of 33 years old. 86 out of 224 with focal seizures showed less than or equal to 50% reduction in seizure activity. 17 out of 38 with myoclonic seizures showed less than or equal to 50% reduction in seizure activity, and 6 out of 10 with absence seizures showed less than or equal to 50% reduction in seizure activity. Ramadan fasting may have an improving effect. Here's more about epilepsy in Ramadan. Ramadan is a month of fasting for Muslims where they fast each day from sunrise to sunset. Time-restricted feeding has shown to have an anticonvulsant effect. The patients were recruited from 2 epilepsy centers in Egypt. All patients were over 12 years old. The fasting causes the body to enter low levels of blood glucose, exhausted stores of liver glycogen, and the hepatic production of fat-derived ketone bodies, which serve as a major source of energy for the brain. And Ramadan causes fatigue, emotional stress, disturbed sleep rhythm and duration, and alteration in the times people take their medications. So seizure first aid. So stay with the person and time the seizure, move or guide the person away from harmful objects, turn the person onto their side if they are not aware or awake, do not put anything in their mouth, do not restrain them, put something soft under their head like a pillow or a sweatshirt, stay with them until they're fully aware, and call 911 if needed. Here's a video from the Epilepsy Foundation on seizure first aid.
The Epilepsy Foundation presents Seizure First Aid, what to do in the event of a seizure. Number 1, stay with the person and start timing the seizure. Remain calm and check for medical ID. Number 2, keep the person safe. Move or guide away from harmful objects. Number 3, turn the person onto their side if they are not awake and aware. Do not block their airway. Put something small and soft under their head and loosen tight clothing around their neck. Number 4, do not put anything in their mouth. Don't give water, pills, or food until the person is awake. Number 5, do not restrain. Number 6, stay with the person until they are awake and alert after their seizure. Most seizures end in a few minutes. And lastly, call 911 if the seizure lasts longer than 5 minutes, if the person is injured, pregnant, or sick, if this is their first time having a seizure, if the person does not return to their usual state, if they have repeated seizures, if they have difficulty breathing, if their seizure occurs in water, or if the person requests medical attention. This publication is made possible with funding from the Centers for Disease Control and Prevention. Its contents are solely the responsibility of the authors and do not necessarily represent the views of the CDC. The views and information provided in this guide are solely those of the Epilepsy Foundation and should in no way be deemed as substitution for medical advice. For more information, visit epilepsy.com/first-aid.
So seizure rescue medications, the most common type are from a group called benzodiazepines. They start working quickly in the bloodstream. They come in pill form, can be placed under the tongue, can be placed between the cheek and gum, and given rectally or by nasal spray. They can only be given by injection at the hospital. The most common used ones are diazepam, known as Valium, lorazepam, known as Ativan, or midazolam, known as Versed. In the United States, we also have nasal midazolam known as Nasolam, nasal diazepam known as Valtoco, and rectal diazepam known as Diastat. These 3 meds can be given outside of the hospital for repetitive seizures, also known as seizure clusters. Nasolam is for 12 years and older, Valtoco is for 6 years and older, and the gel is for people 2 years and older. When deciding on a rescue med, a neurologist will consider how fast it will take to act, what forms will be available, who can administer it during the seizure, how easy it will be to use, the cost of the medication, side effects, and everyone's comfort level when using a medication during a seizure or seizure cluster. So this is about what rescue meds are available.
In the United States, the U.S. FDA has approved 3 medications for out-of-hospital use for the treatment of acute repetitive seizures or seizure clusters. These include Diastat, which is a diazepam rectal gel, Nasolam, which is a midazolam nasal spray, and Valtoco, which is a diazepam nasal spray. These 2 nasal sprays have been recently approved. Other medications that are commonly prescribed and used for out-of-hospital rescue treatment but have not yet been approved by the FDA include things like oral lorazepam or diazepam or clonazepam.
In young children, one of the most commonly used rescue medication is rectal diazepam. This is an FDA-approved therapy, and it can be given by anyone. It doesn't need to be given by a medical professional, and it can be given in a person's home or in any outside hospital locations. It's a medication that is given rectally, and it's a pre-dosed syringe. The syringe is put into the rectum, and the dose is administered. Because it's given rectally, it is a medication that can be a bit socially embarrassing to give. And so we typically use it for very young children, or it can be used in the privacy of the person's home. 2 new therapies that have been recently approved by the FDA are given nasally. And so these are therapies that are actually very easy to give if somebody is in a public setting. The 2 therapies are nasal midazolam, or an agent called Nasolam, and this has been approved for persons 12 years and older. And the second type of therapy is nasal diazepam, also called Valtoco, and that is approved for persons 6 years and older. These come in pre-measured doses. It's very, very easy to give them. You simply put the device into the nostril and squeeze, and the medication is given into the nostril. These medications can come as orally disintegrating wafers, or wafers that disintegrate really quickly when they're put into the mouth. And an example of that would be clonazepam wafers. There are also liquids that can be given into the buccal cavity or into the cheek. and that would be either lorazepam or diazepam. And then there are tablets that can be given under the tongue.
So next up is seizure alert dogs. Seizure dogs are trained to alert someone who is having a seizure. They're considered a service animal, and how a seizure dog helps someone depends on a person's needs and abilities. The dog can be trained to stay or lay next to the person during a seizure, or bark to alert others, or fetch someone, or help, or even be able to detect a seizure before it starts. Children must be at least 12 years old to have a seizure alert dog. Seizure dogs have been known to provide comfort and companionship to their child, help children build their independence, help children who feel isolated bond with their peers, go with children to medical appointments to lessen anxiety, fear, and stress, be a part of different therapies, help with risk and safety, partner with parent or classroom aid during behavioral difficulties, and provide reassurance to families. Seizure alert dogs are allowed in public schools under ADA and allows the students to use the dog under IDA and Section 504. Now, here's where it comes to the seizure alert dog's training. The dog must go through 2 years of training with a reputable trainer. The training includes basic skills along with skills for responding to seizures. A dog's personality and temperament are considered when it is being trained to become a seizure alert dog. Programs are available that allow parents, guardians, healthcare aides, and other adults as the child's partner during the training with the dog to benefit them, the family, and the dog. And bonding the child and adult partner with the dog is important to do from the beginning. So there are multiple categories for seizure detection devices. The categories are non-invasive alerting systems, epilepsy management alerting systems, implanted surgical technologies, non-tech safety resources, and EEG monitoring. So an MFIT movement monitor falls into the non-invasive alerting system. It's patented and clinically tested nighttime alerting system, alerts abnormal, repetitive, and convulsive movements. It's easy to install. There's no body contact. The main components are a bed sensor that goes under the mattress and a bedside monitor, and was created in Finland. The Epi Monitor, Embrace Plus, and subscription is again a non-invasive alerting system created by Empatica. It is a wearable watch and smartphone application. It detects generalized tonic-clonic seizures and monitors epilepsy. It's FDA cleared for adults and children 6 years and older. It has 7 days of battery life. It requires a compatible smartphone within 25 feet. So the subscription includes seizure alerts, seizure diary, sensing positions, and alert location. The Plus subscription includes manual alerts, sleep and activity tracking, and diary PDF exports for caregivers and doctors. So SAMI, the sleep activity monitor, is a non-invasive alerting system, which is wearable free. It's a nighttime movement monitor appropriate for all ages. Parents, caregivers, and individuals can watch for abnormal movements in their child or loved one's sleep without losing their own sleep at night. It can be configured to alert both rhythmic and non-rhythmic movements, can choose how much motion to look for, automatically records the motion. The device will alarm and show live feed with video and audio when abnormal movement is detected. It works in complete darkness and does not require Wi-Fi. The portable pulse oximeter, non-invasive alerting system, attaches to a fingertip or toe and measures heart rate and blood oxygenation percentage. Both of these are affected when a person is seizing and requires a prescription and the use of a durable medical equipment facility. And the Inspire app is a non-invasive alerting system created by Smart Monitor, can be used on Samsung or Apple Watch, detects repetitive shaking movement. When abnormal motion is detected, the app will alert whoever the user designates. The alerts include date, time, location, and duration. The user can get help by pushing a button. Physicians can review reports of events, and there is a monthly subscription fee. EpiPal app, it's a non-invasive alerting app, connects families and caregivers for epilepsy management and safety, detects seizures, send alerts for epilepsy related emergencies, journal together, monitor medication adherence, and stay connected with the support group. It's available on Apple Store and Google Play. It connects to the Apple or Android Watch. The Owlet Babysat, so it's a non-invasive alerting system, prescription home monitoring system, ages 1 to 18 months. It measures SpO2, pulse rate, and motion levels through a sensor in a sock. Alarms for hypoxia, high pulse rate, and low pulse rate due to a base station and caregiver's phone app. Not intended to be a seizure monitor, but measures indicators for a seizure. It's wire-free and adhesive-free, compatible with Apple and iOS users, and requires a prescription. Capture Proof is an epilepsy management mobile app. It's a visual health record. Patients and healthcare providers share photos and videos. It's a visual seizure diary. They track the progression of seizure activity over time, and it's free. Seizure Tracker, epilepsy management mobile app created by parents with a son who has epilepsy. Patients, doctors, and researchers can use the tools to help them understand the connection between seizure activity and anti-epilepsy medications. Patients can create a report with their seizure activity and their medication history to share with their medical team. Users can record seizure activity as it is happening, and it is free as well. The Seer Health Seizure Tracker app. It's an epilepsy management mobile app backed by decades of research and uses recorded events to predict this user's next seizure. VNS therapy, it's implanted surgical technology. VNS, vagus nerve stimulation, implanting a pacemaker-like device in the chest that generates pulses of electricity to stimulate the vagus nerve. Treats drug-resistant epilepsy. The VNS gives mild pulses to the brain through the vagus nerve to help prevent seizures before they start and stop them if they do. More about the VNS therapy. The side effects are hoarseness, shortness of breath, sore throat, cough. Total elimination of seizures is rare. Significant reduction in seizure frequency, decrease in seizure activity. It's FDA approved for patients 4 years and older, and it's an outpatient procedure. NeuroPace's RNS system. It's implanted surgical technology. RNS stands for responsive neural stimulation. Surgical implantation of a matchbook-sized device that attaches to the surface of the brain. Its closed-loop approach to prevent and stop seizure activity continuously monitors brain activity. It senses the onset of a seizure, sends electrical stimulation to stop the seizure once one is detected. It's treatment for uncontrolled epilepsy in adults, and it's evaluated in 3 clinical trials. Visualase laser surgery / Medtronic. It's an implanted surgical technology, minimally invasive MRI-guided laser surgery for people who have epilepsy that cannot be controlled by medication. It targets areas of the brain causing seizures. The light energy from the laser heats the brain tissue, thus destroying it. One switch is needed to close the wound, and it's an overnight hospital stay. The SleepSure anti-suffocation pillow. It's non-tech safety resource developed and produced by Seizure Alert Australia. It's adjustable sizing, fully machine washable, breathable, durable, practical, comfortable, hypoallergenic, latex-free, and chemical-free. 3D spacer fabric technology, but it's not FDA approved. Drop support harness. It's a non-tech safety resource. Fall support harness. Manage and control falls to reduce the risk of injuries. User can walk unrestricted but still have fall support with the support handle. The support handle allows for a higher grab to reduce back strain. Variety of children's and adult sizes. Selection is based on user's height and weight. Cost range is $99 to $129 and can be used inside and outside the home. Sleep Safe pillow. Again, it's a non-tech safety resource, breathable design. Head movement compresses and decompresses the aero matrix chambers, which causes air to flow from the sides and ends of the pillow. Allows air to flow around the face. Flushes exhaled breath and carbon dioxide away from the user's nose and mouth, and is often ordered in pairs. Choking rescue device, non-tech safety resource, non-invasive, rescue suction device, suction-based airway clearance, use an airway obstruction emergency. So, why would someone do genetic testing? To explain why they have epilepsy, to choose medications, to predict if epilepsy will stop by itself, to predict possible learning/developmental difficulties, to understand SUDEP risk, to prepare for seizure risk in siblings, prenatal/IVF testing, and to connect with others that have the same condition. The recommended genetic tests for epilepsy are multi-gene panel, chromosomal microarray, whole exome sequencing, and whole genome sequencing. Steps for genetic testing in epilepsy are the diagnosis of epilepsy, which includes the EEG, the exam, the rule out of other conditions, referral to genetic counselor, the pre-test counseling appointment, which includes the review of medical history, family history, other genetic tests, discuss the test options, the cheek swab, saliva, or blood sample. Then the insurance authorization, which usually is requested when the test is ordered and performed by the lab. And then obviously you have the testing, which takes 2 to 6 weeks to get the results. The post-test counseling appointment where you review the results and discuss more testing if required. And then the clinical correlation where you go to the neurologist to discuss the updates. The possible genetic testing results is positive, which will also be called pathogenic, where the variant is proven to cause symptoms. Negative, where either no variants or only benign variants. Uncertain, variant is present, but more evidence is required for a pathogenic or benign result. Incidental, variant causes a condition that isn't being tested for. Or carrier, one variant is in a recessive gene and does not cause symptoms. So next is seizure action plans. It contains guidelines on how to respond to a seizure based on a patient's medical history, includes health and medical information specific to the patient to help people recognize their seizures, helps people take the appropriate steps to help them during a seizure. Seizure action plans are important because seizures can be life-threatening and can reduce the response time to seizure. So here's a video that explains seizure action plans.
So let's talk about seizure action plan. So what is seizure action plan? So it is a detailed seizure related information about the student. So what we say is that every person with epilepsy may not need rescue therapy, but every person with epilepsy needs a seizure action plan. So who uses it? Every adult individual who interacts with your child on a day-to-day basis, specifically school teachers, school nurses, coaches, and other individuals with supervisory role should receive and review seizure action plan. Where it is kept, typically a school nurse serves as gatekeeper of the seizure action plan, and it is advisable for school nurse to have this seizure action plan in students' file in the with the classroom teacher should also have a copy. And again, parents and physicians should also have a copy of it. Who will benefit? Almost everyone, the kid and the people around the child will benefit with seizure action plan. Students are more likely to receive an appropriate response. School teachers and school nurses have, when they have the necessary information to respond and provide the first aid when the child has seizures. Where to get it? I mean, there are a lot of resources that you can get it, but one I recommend is it's very wonderful, good plan, very diagrammatic pictures on Epilepsy Alliance website that you can get from. And I walk you through one of the seizure action plan that I generally give to my patients. It's all customized. So this is for our patient Duncan Warrior. And then it has triggers. So for this kid, it triggers, for example, fever, sleep deprivation, flashing lights, patterns of seizures. So this diagram is pretty self-explanatory for our kid. However, if some patient has different kind of seizures, then this seizures, then we put it here in patterns of seizures. If there are any allergies, then we put it here. And then we put some notes that when does he require rescue medication, what kind of seizures, if he has, then he will need the rescue medication. Then we will point it out in this note section here. And then this is the second part of the seizure action plan where what needs to be done when the child is having seizures. So this is pretty self-explanatory. You first thing you need to do is time the seizures, keep person safe, don't restrict the child. If he's seizing, let him do whatever he's doing. Stay with the person and keep the record. And then this is the second part is provide the rescue treatment where we write exact dose of the medication, how to give the medication, what is the route of administration, and then the last part is call for emergency in the situation if the seizures are longer seizures, if they're unusual seizures, so on and so forth. And then we also give our phone number back and our hospital on-call provider emergency call number there as well. So again, seizure action plan. So after your health, when you go for your first visit or your second visit, any of the visits when you go to see your doctor, neurologist or your epilepsy doctor, make sure that you have that seizure action plan either signed at the first place, and then if you are going for follow-up, make sure to update it. And once you update it, make sure to have multiple copies. Keep one with you all the time in your purse, pocket, wallet, backpack. Put one in the central place at your home. Give a few to people who are with your child more frequently. And then you can give it to definitely you should give it to your school nurses, school teachers. And then and if your child is going to a camp or other programs where he or she may spend a lot of time, give a copy to a camp nurse, counselor, or person in charge. And again, during all this process, make sure that your child knows that you are doing this and this is a part of this process. So he's not left out and he knows exactly what's going on when he has a seizure.
So there was a seizure rescue medication study done in July 2021 with 49,341 school nurses received a survey and only 866 of them replied. Of the 866, 45.7% said they used rectal diazepam gel, 9.3% said they used the midazolam nasal spray, and 6% used the diazepam nasal spray. 58.7% had not been given authority to give rescue therapies. Before 2019, rectal diazepam gel was the only rescue therapy for seizure clusters approved by the FDA. Rectal administration provides challenges in the school setting, such as privacy for the student, availability of the nurse at the time of the seizure, issues of staff members' anxiety, and fear and issues around who can administer the medication. In 2019-2020, midazolam and diazepam nasal spray got approved by the FDA. Midazolam nasal spray is also known as Nasalam and will be seen with students who have epilepsy that are 12 years or older. Diazepam nasal spray is also known as Valtoco and will be seen with students who have epilepsy that are 6 years or older. 77.1% of the nurses treated less than one seizure per month, 10.1% treated one seizure per month, 9.3% treated 2 to 5 seizures per month, and 3.5% treated 6 or more seizures per month. 93.6% of the nurses stated that students were required to have a seizure action plan. Then there was a study done in Denmark where it studied children born in Denmark from 1997 to 2009 who participated in the Danish National School Test Program from 2010 to 2019. It was norm-based test scores in language and math on the scale of 1 to 100. 4,659 children had epilepsy out of 582,840. The median age of onset was 7.5 years old. The comorbidities of epilepsy discovered were psychiatric disorders, intellectual disabilities, and ADHD. Children with epilepsy need widespread support whether they have a comorbidity or not. Epilepsy affects 0.5% to 1% of children in high-income countries. Poor academic performance is due to underlying causes of epilepsy, seizures, anti-seizure medications, the social consequences of epilepsy, and school absences. Even children with typical intellectual function and who have epilepsy will face academic challenges. The decline begins around the years of diagnosis and does not normalize again. And 47.2% of children with epilepsy had 15 or more days of school absences a year. Then there was a study done in Sussex on 85 children ages 5 to 15 years old with active epilepsy. They underwent comprehensive psychological assessments measuring global cognition, working memory, and processing speed. 24% of the children scored an IQ below 50, 40% of the children scored an IQ below 70, and 58% of the children showed memory underachievement. There is a high rate of global and cognitive difficulties in childhood epilepsy. It is most noticeable in working memory and processing speed. Childhood epilepsy is associated with negative psychosocial outcomes. The Children with Epilepsy in Sussex Schools study was used to identify the cognitive and behavioral difficulties experienced by school children with active epilepsy. 60% had at least one mental health disorder, 55% experienced cognitive impairment, 40% have an intellectual disability. Then there was a study done in Lebanon, where 7 to 14 people out of 1,000 people suffer in countries with moderate to low income. Most frequent neurological condition encountered by school professionals. Epilepsy can affect learning through cognitive or behavioral dysfunction, memory or concentration issues, psychosocial comorbidities, learning disabilities, and attention deficit disorder. So the school staff there were not adequately educated when it came to sports activities and students with epilepsy. And various studies have shown a lack of information in multiple fields when it came to school personnel and epilepsy. The layout was a pre-test, conference, and post-test. The conference was either 90 minutes or 210 minutes. The teachers and counselors evaluated were familiar with epilepsy and tolerant, but had gaps in their knowledge. It showed successful in filling in the gaps of their knowledge. Then there was a West Cheshire study. It was an observational study of 250,000 children in West Cheshire Health District secondary schools. Epilepsy was 4.1 per 1,000 children in the school district. It was 10 times higher among children who had special needs. The students with epilepsy and that required special education had less controlled epilepsy, but they were not taking a greater number of anti-seizure medications. A physical disability occurred 5 times more in someone with epilepsy and a special education requirement. Epilepsy in students at a mainstream school was more controlled. 1/5 had poorly controlled epilepsy, and a few had physical disabilities. Epilepsy is more challenging to control in students with special education needs. Health and education professionals need to be able to support students with epilepsy, some who are also facing special needs or physical disabilities. EEG reports were reviewed to help classify seizure types. So then there was the Seizure Smart Schools project. There was a partnership between a Midwestern school district and the Epilepsy Foundation of Minnesota to provide education and resources to staff working with students with seizures. 26 school nurses were trained as seizure management educators, and they instructed staff in 21 schools on seizure awareness and response. The school nurses used seizure management resources, a procedural guideline, and care plan updates. School nurses' confidence in taking care of students with seizures increased. The Epilepsy Foundation of Minnesota is using this as an example for its Seizure Smart Schools program. A national survey done in 2005 found that only 60% of 573 school nurses felt confident taking care of students when they were having a seizure. More information on this study was that this Midwestern school district had 42 schools that served 39,000 students. The district had at least one student with epilepsy in each school, 312 with an epilepsy diagnosis, and 514 recorded seizure event responses. This is the first school district to conduct a district-wide change as part of the Seizure Smart Schools program. The nurses went to multiple conferences to learn about the new protocols and information. The nurses went on to train the staff in over half the schools on seizure recognition and response. Staff, parents, and students have access to seizure resources through the website created. Then there's the ECO model. Some regions of the U.S. have limited access to interactive evidence-based epilepsy education programs. Adapting the Epilepsy Foundation's school nurse education program to the ECO model. It would be delivered by a team of interdisciplinary epilepsy specialists over a video conference. Post-program surveys were given at the end. There were 166 school nurses from 13 states. Program satisfaction was rated at high by over 90% of the participants. Telemonitoring was used by the ECHO model, is effective for connecting epilepsy specialists with school nurses to educate them on epilepsy nationwide. Pediatric neurologists will work with schools to make sure seizure action plans and rescue medications are discussed. The telemonitoring allowed people to share difficult cases and get feedback. So, next up is Sam's Law. Samantha Watkins died of SUDEP 3 months after her epilepsy diagnosis. Sherry Dudeau, a teacher in Texas with epilepsy, worked to pass Sam's Law. Sam's Law is the name of the Seizure Safe School Law in Texas. It was introduced by Travis Clardy in District 11. All Texas public school personnel have to be trained in seizure first aid and recognition. It also allows parents and doctors to send medical information and detailed instructions of care to the school. So here is some information about Sam's Law.
Back in December of 2016, the death of a Kilgore High School student shook East Texas. Sam Watkins died after having a seizure, then slipping into a coma. And now a former teacher and state rep have teamed up and are hoping that they are dubbing Sam's Law could prevent such a tragedy. KTK's Matt Thibodeau has our story.
State Representative Travis Clardy and Sherry Dudeau have finally gained some traction in their efforts to push Sam's Law.
Dudeau didn't start her mission hoping to create a new law. Originally, she spoke with the TEA hoping they could train teachers in seizure first aid.
And they said that they could not, that any training for the public school employees had to be a law.
Dudeau then contacted Clardy.
Since that time, we've been in dialogue with the Sherry and with the Epilepsy Foundation and others, and have really found this to be an important issue, and it's getting a lot of traction.
Representative Clardy said he had no idea just how many Texas school children have been diagnosed with epilepsy.
Recently, the Epilepsy Foundation of America has stated there are 47,200 children in Texas that have epilepsy. I knew I needed to do something.
One of those was Sam Watkins of Kilgore, the law's namesake. On Labor Day 2016, she had a seizure, then another 3 months later that killed her.
The problem with epilepsy is everyone recognizes the tonic-clonic or the grand mal seizure, where you fall, you convulse, but there are some seizures that are very, very subtle.
Dudeau says seizure first aid training is simple.
The Epilepsy Foundation has come out with a fantastic video for training. It's a fairly short video, 20, 30 minutes.
A half-hour video that could possibly prevent another tragedy. Matt Thibodeau, KETK News.
Next, there's the Lindsey Crunk Act, the first Seizure Safe Schools bill to get passed in the country. It was passed in 2018. It's Kentucky's version of the Seizure Safe Schools Act, and it was signed into law by Governor Bevin. And here's a video about it.
Well, just 5 short years ago, a Scott County teen was diagnosed with epilepsy. And since then, she's been working to make schools safer for kids like her.
And last year, Governor Bevin signed a bill into law in her honor. Now other states are following suit. Claire Crouch has more in this Making a Difference.
What's that? Lucas's graduation.
Lindsey Crunk is only 17, but she's proving it's never too early to start creating change.
Weird that it's happened in such a short time, but I'm glad that it's happened.
Lindsey was diagnosed with epilepsy in 2014. The diagnosis was a surprise and scary for her family, especially for mom Cindy.
I didn't know enough about epilepsy. I didn't know what to expect.
Cindy felt alone, and as she realized so many others were just as much in the dark, she turned to advocacy groups. Before long, she and Lindsey started taking action themselves, advocating for what they call Seizure Smart Schools, a push to mandate seizure first aid training.
Having seizure first aid training is as important as CPR. It's life-saving.
Their work culminated last April with Governor Matt Bevin signing the Lindsey Crunk Act into law, making Kentucky the first in the nation to require teachers and personnel at public schools to undergo training in seizure first aid. Lindsey has since received a national award for her work, and more powerful, other states are now adopting their own seizure smart laws.
We're just getting started. This is the tip of the iceberg as far as we're concerned. Super proud of you though.
Thank you.
All your hard work is paid off.
In Scott County, Claire Crouch, LEX 18 News.
It sure has. And if you are feeling alone in your battle with epilepsy or just need more information, you can get more information on our website, lex18.com.
So another one is Brindley's Act. It's Maryland Seizure Safe Schools Act. It was passed in April 2022. The family and their advocacy group started working on the bill in 2019 when she was starting preschool. They worked with many families from across the state to share their stories. They put in the bill 3 times through the Maryland General Assembly, worked with many organizations in Maryland and across the United States. Maryland becomes the 15th seizure safe school state.
For a parent whose child suffers from epilepsy, sending them off to school here in Maryland each day really comes with a lot of added stress. That's because very few teachers and administrators, even nurses, are trained to deal with seizures. But that's all going to be changing. WMER2 News' Nordea Lewis tells us how a mother's love push for change.
Senate Bill 229, Senator Young, Education, Public and Non-Public Schools, Seizure Action Plans.
Brindley's Act is a bill created by Lauren Shingler, who is the mother of an 8-year-old named Brindley who suffers a rare seizure disorder. Lauren spent years advocating for change by encouraging school seizure safety. And now, 4 years later, the bill is approved and Maryland schools will be required to have trained seizure experts on site.
Seizures are so common, and we need to make sure that everyone is equipped to handle those emergencies, and knowing that she can go to school and be safe at school, it's really comforting and reassuring.
I'm so happy for not only our daughter, but all the children in Maryland who have seizure disorders or who might have their first seizure at school to finally feel a sense of protection and safety.
Brindley's Act requires all schools to be seizure safe by fall of 2023. It'll require schools to provide seizure training to all staff members so they'll know how to recognize and respond to a seizure. This is especially important for younger kids, as seizures account for the top 3 reasons calls are made to 911 from elementary schools.
1 in 26 people will be diagnosed with epilepsy. 1 in 10 will have a seizure in their lifetime. So this will not only help students and staff that already have known epilepsy or known seizures from other medical conditions, but anytime a person has a first seizure at school, this will allow for everyone to be trained.
This is amazing.
Diana Bremen, who suffers from epilepsy herself, has been an elementary school teacher for 17 years. Bremen says she and her colleagues have never been offered epilepsy training by schools, but with this new change, she's excited to offer more comfort to families.
I just am so thrilled that we're able to just do the best job and the correct way to help them. So hopefully this is just something that helps teachers be more confident and comfortable, ease teacher anxiety, children and family anxiety, and really just keep our kids safe.
In Baltimore, Nordea Lewis, WMAR 2 News.
So here are some organizations that support seizure safe schools: Paul's Purple Warriors, the Cameron Boyce Foundation, Angels of Epilepsy, Purple Peace Foundation Cure, Danny Did, American Epilepsy Society, Child Neurology Foundation, and the Epilepsy Alliance. And that's not even all of them. Some other resources for you as a teacher. The Epilepsy Foundation has provided online and in-person training opportunities over the years and hosts multiple walks to end epilepsy every year. The Danny Did Foundation provides funding and education for seizure detection devices, and Empowering People's Independence provides summer camps for kids and adults with epilepsy, support groups, enrichment, activities, webinars, raises awareness through fundraisers, educates schools, families, and businesses, and has group homes for adults with epilepsy that need extra support. So like I said, these are resources for you, parents, and students. So now let's analyze and interpret the results of the training. This training will reduce the anxiety, depression, and negative self-image in children with epilepsy. It will also allow faculty and staff in school to feel more confident when working with students with epilepsy. And it will also help faculty, staff, families, students, and doctors to work together to determine what is best for the student. So implications. Faculty and staff will know more about epilepsy and how it impacts their students. Students will feel safer going to school. Parents will feel safer when sending their children with epilepsy to school. Doctors will feel safer when their patients are in school and will be more willing to work with schools. Faculty, staff, parents, students, and doctors will have an easier time working together because they all understand epilepsy now that the faculty and staff are trained. Limitations. Not every state has the Seizure Safe School Law. Not every district in Connecticut uses the same training. Rely a lot on technology for this training. Like I said, a majority of this training is in the PowerPoint. They do have the handbook, which has part of it, like the reminders, and they do have the posters up around the school, but a lot of this training was in that PowerPoint. And also rely on faculty and staff being willing to learn about this topic. You know, as we all know, sometimes people doze off if it's a topic they're not interested in, so you have to rely on the faculty and staff being willing to learn about the topic. And rely on faculty and staff implementing and remembering what they learned that is not in the handbook or on the poster. The potential future for this, as more states adopt the Seizure Safe School Law, this training can spread into other states and districts. This training can be used for businesses, corporations, other workplaces that aren't schools, or even for families that have a loved one with epilepsy. As people become more aware of epilepsy, this training might no longer be needed or can be a yearly review in the workplace. This training can motivate someone to try to help find a cure for one of the many types of epilepsy. And these are my resources.